Bienvenidos a Hemisférix, el podcast de fisioterapia y neurorehabilitación, presentado por Javier Sánchez Aguilar. I am with Susan Wall, physical therapist from the USA, creator with Jan Utley of the Force Use concept. And it's a real pleasure for me to have her here at Hemisférix to talk about her clinical journey and her specialization in neurorehabilitation and obviously in force use. This is going to be, I think, a very interesting interview since it's not usual to meet a physiotherapist with more than 50 years of experience and who can tell firsthand about the evolution of neurorehabilitation. I have known Susan for a few months as she collaborates with CEN, with the European Neuroscience Center, teaching courses of force use and also working a few weeks from time to time. I think that we are in front of a professional who has many things to tell us and who also has an energy to teach and work that I think is not normal. So this interview is a way to find out about his career, and it is also a tribute. I think, at least in Spain, not many people know Susan as a force use concept, obviously. So here we are. Here we have the opportunity to know her. So hello, Susan. Welcome to Hemisférix.
Thank you. I'm glad to be here.
As I spoke with her a few days ago, this interview is probably two-part because there is so much to talk about, and imagine what 50 years of clinical experience can bring. What do you think about that?
Well, the idea of 50 years, I can hardly even begin to think about that it was 50 years. I remember the first day of starting university to study physical therapy, and I never in my life even thought about the day I would finish my training. And after that, I didn't think about the idea that I would be working for 50 years. The years just go by and you keep working and you keep changing things and it continues to be interesting. And then suddenly someday somebody says to you, you've been working 50 years. And you think to yourself, is this when they send the old therapist out to some place to just graze until they die? Or what is this about? 50 years.
It's a lot of time.
It is a lot of time. A lifetime.
A lifetime. Maybe the best way to start this interview is to start at the beginning. You graduated in the 1970s, right?
Yes, 1970 exactly.
The first question I want to ask you is, why did you choose physical therapy? And how did you choose next neurorehabilitation?
Okay, you're going to be very surprised. I didn't choose physical therapy. My mama did. She said to me, Susan, I've been talking with a friend of mine who's an anesthesiologist, and we think that you should be a physical therapist because you have a little problem with your weight, being a little bit overweight, and maybe it would be good for you to have a job where you get some exercise and you move around. And I thought, and I looked at the possibilities in the state of Georgia where I was living in Atlanta, and I realized there was no school in the state of Georgia. And that was the clue. I wanted to go away from home. And so I started looking for places to study in Boston, as far as I thought I could go away from home. And so I said, yes, good idea. I'll be a physical therapist. I had no idea what physical therapy was till the day I started. It was chance, a good chance, lucky. I was very, very lucky.
And
so I became a physical therapist for all the wrong reasons.
Okay, but why next neurorehabilitation? Because most of physical therapists, I don't know, in the 1970s, most of physical therapists want to be a sport physiotherapy, to do some traumatological physical therapy is the most typical. But why neurorehabilitation?
That was the only part of my training in the university that I thought allowed for any creativity. Everything else looked like it had a structure that said, on day one, you do this, on day one, you do this, something else. And that it was about structure, and everything you did was already decided. And in neurophysiotherapy or neurorehabilitation at that point was a new profession, a new specialty. It was a time when people who've had head injuries or spinal cord injuries were just starting to survive their injuries. And so there was lots of room for creativity and figuring out how to solve their movement dysfunction problems. And that spoke to me. It was about creativity.
Okay. And how was the training in neurorehabilitation at that time? What methods?
There was no training in neurorehabilitation at that time. At that time, there were a number of people trying to figure out what we should do. The only structure was a structure that was used to understand baby development. So when we first started seeing clients who had survived stroke or head injury, we used the Giselle motor milestones structure. The person needed to get on their stomach, and then they had to prop themselves up on their forearms. And then, so we went through the motor milestones. And then if we couldn't get past quadruped or we couldn't get past kneeling, then it was the fault of the client. And then the client was said to have plateaued, and then the client goes home. It wasn't the fault of the therapist not being able to solve the movement dysfunction problem. It was the fault of the client. And this was a huge problem for me. But there was actually no training in neurorehabilitation for solving movement dysfunction problems caused by stroke or head injury.
That was like the neurodevelopmental therapy, or not?
It sort of, it was called that later, but that's exactly what it was. We used the developmental sequence, which came from a total different source, from Dr. Giselle, who was a behavioral psychologist and just studied baby development. But right after that, in the 70s, Mrs. Bobath and Signe Brunstrom and Maggie Knotts and a number of other women and men who were trying to figure out what neurorehabilitation should be about and what one should expect and what we should do, all came together and had a conference called New Step.
New Step.
That took place in Boston the first time during the years that I was in the university. And that was the first even attempt at a structure and a course for believing that clients could actually recover. They believed it without having any scientific information at that point. And in fact, in 1971, I took my first, what was called Bobath Adult Hemiplegia course, given by Mrs. Bobath. It was the second course ever given with that name, that topic. And it was in Basel, Switzerland. And I took that course and it changed my life.
Why?
Until that time, I was just doing what I was taught. I would bring my notebook every day, put it under the mat table where the client was. And if I didn't have someone that I could look at in the room and copy other therapists, I would take out my notes and try to figure out what I should be doing. And for me, that was just the most terrible thing. I was copying other people. I wasn't solving the problems the clients were describing. Will I ever play with my grandchild again? Will I use my arm? And I could go home at night and cry because I had no idea how to make that person's life worthwhile as they described it. So under those conditions, I stopped working in Philadelphia, Moss Rehabilitation Hospital. And I went to Switzerland. And within 6 months of arriving, I saw that first flyer, folder, prospectus, how we used to do before social media to announce courses. And I saw Mrs. Bobath, who I had had maybe a 5-hour course from in the university or about her treatment, was coming to Switzerland to give this course in treating people with adult hemiplegia. And I had to be in it. And I made myself go because if I wasn't in that course, I probably would have stopped being a physical therapist because I didn't understand what I was doing. And I thought, okay, being in Europe is great. I'll learn about the world, but I'm still not learning how to be a physical therapist, or at least what I thought a physical therapist should be.
We will talk later about Bobath. That's a big topic. But speaking about those first work experiences, what was the first thing you came across when you started working in neuro? What kinds of therapies were used?
All of the therapists that I came across. So I was working at Moss Rehabilitation Hospital in Philadelphia. 2 of them had been in what we called the pediatric course with Mrs. Bobath in America. And some of them had been to Vallejo and taken a PNF course. And that's where the Maggie Knotts gave the PNF course in the United States in a place called Vallejo, California. And at that point, I worked with Dr. Richard Herman, and he was very interested in orthotics. And all we did, we saw clients who had stroke. All of them were above, probably over 75 or 80 years old. We called them survivors. We had a couple of people who had survived head injuries caused that they had incurred in Vietnam, and we had many amputees from Vietnam. But all we did was try to get them on their feet. We didn't know better. We didn't know worse. We had no idea if they could get stronger. We didn't know anything else. And we braced them. We braced their leg up to their hip. And then afterwards, we cut the brace down to below their knee. And that was sort of the structure. Get them on their feet with bracing or with casting. And try to teach them to walk. Their arm was in a sling. And we lied to them. We said, when you can walk, then we'll deal with your arm because you can't deal with it before you can walk.
So
and
typical.
By that time, they would be home. And we would never deal with their arm at all. That was my experience. My experience was very negative in terms of the client reaching any kind of functional independence.
It must be remembered that at that time it was not known what neuroplasticity was, which is now like fashionable. So the mere idea to recover function, not mere compensation, it was really a big revolution.
Yes, it was a revolution. And for us, it was sort of like believing in a miracle.
We will speak about the neuroplasticity or the advances in neuroscience that we know today. Many therapists were concerned a lot of years ago, I think. So speaking about Bobath, it's a big topic. I finished my physiotherapy degree in 2016. And the Bobath concept has been the gold standard or the basic kit for every physical therapist, occupational therapist. And there is always discussion around the Bobath concept. This is Bobath, this is not, the evidence, and so on. But here we have the privilege of being with a person who met and trained with the Bobaths. So I want to ask you, what were the Bobaths like? What impression do you have of them?
First of all, Mrs. Bobath was a very strict and goal-directed woman. She was warm in her heart, but she put everything about how to make the client better, and her beliefs came in front. She was very strict. And her husband was someone who believed in her desperately, loved her and believed in her desperately, and spent his whole life trying to figure out why clients got better when she did whatever handling she did. why the client improved. And so he spent a lot of time in the library, and he spent a lot of time trying to justify what he did.
We can say that Mr. Bobat is the theoretical part of the Bobat, and the Berta, the practical, the creativity. We can say that?
Yes.
Okay.
Bertie was the creative one. She could feel intuitively what needed to happen next. She knew how to create situations that made the client feel safe and would allow themselves to attempt to move, to do what she asked them to do with her hands and with her voice.
Okay. What was the Bobat concept like at the beginning when you started to train? Because the Bobat concept is obviously a concept, not a method. So it has evolution. So how was the Bobat concept at that point when you do the course in Switzerland?
Mrs. Bobath thought of it as a philosophy. She thought of this as a philosophy. What does that mean? She believed that recovery could occur, and we had to create situations for that to happen. She believed in recovery, but she believed that it is a basic philosophy on which we would then create handling strategies. And what she always said to us, and what I took away from the very beginning, was that as the scientists were going to figure out what happens in the brain, and we were going to keep learning more over the years. And every time the scientists figure out more about what we now call recovery, what we call plasticity, we were supposed to, as therapists, make up handling strategies, create handling strategies that use the new information. That for her, Bobath, which he hated that whole idea of calling it a name, was not a cookbook with a bunch of exercises in it. Whatever she was doing today, she was sure that in 3 years with new science should be changed, and it would keep developing. I think her followers became very rigid. And one of the reasons she didn't even want to write a book, which she never really wanted to write, was because exactly happened what she predicted would happen. In a course, somebody would say, read page 35 and 36 or 38, and tomorrow in the class we'll discuss it and practice the strategy. For Mrs. Bobath, that was like poison. That was not what she had in mind. In fact, she allowed herself to change constantly. And I'm going to tell a little story about her.
Okay.
For a long time, she used quadruped and then 2-point kneeling, being on your knees, as part of a process, like when baby development, to work yourself up to being in standing. So I took one course, the basic course, and that was in that course as something we practiced and discussed. And then about 2 advanced courses later, she stands up in front of the class and she says, I'm not doing quadruped or 2-point kneeling anymore.
Oh.
I'm going straight to standing. We don't need to do that. And one of the things about Mrs. Bobath was she didn't tell you why she made that choice. She didn't tell you what was behind it. She just said it. And there I am sitting in the class, young, 50 years younger than now, for example, or 45 years younger than now. And I thought to myself, like a young person does, that's because she's just so good at handling. I guess I'll still need to do that till I get better. It took a long time for us and me to figure out why she didn't want to do it anymore. Like, because your foot isn't the surface that needs to be on the floor. It doesn't have the skin receptors that activate muscle. The hip is then too far behind the knee when you're in 2-point kneeling. It doesn't prepare the hip or knee for standing, two joint muscles. But she never would say any of that. She just chose not to do it anymore. And she left us to figure out why. She was a very interesting woman.
What is the most valuable thing that you rescue from that time, that conversation with the Bobat, that courses? Could you put into practice in your work?
As I said, that first Bobath course made me into a therapist who believed in therapy and believed in the possibility of recovery. What I took from that course was my responsibility to create handling strategies that solved the movement dysfunction problem of the client. That I was given the right to make up, I was given the responsibility to make up those strategies, and that the reference point was supposed to be what we called then normal movement, not adapted movement like we learned in school, a client with the stroke walks or somebody with Parkinson's, how they walk, and your teacher described it and showed you how they did it. That wasn't the reference. The reference was supposed to be return to more normal, optimal movement strategies, and that my handling had to reflect attempting to get to that point. That's what I took from Mrs. Bobath. It was like being free. I was free of my notes from school. I was free of everything. I was free to think and create handling strategies. That's what she gave me.
So do you think that that handling is very useful or necessary for every therapist?
I don't quite understand the question. I think that every therapist should be responsible for creating handling strategies that solve the client's movement dysfunction problem. I do. I think that's a responsibility.
Okay. And when did you learn that quite a dogma of inhibition first and then facilitation? That for me was a dogma, no? First inhibition, then facilitation. It was at that point that you learned it?
First of all, I learned that from Mrs. Bobath early on when she would make somebody lay down and try to cause inhibition to occur. And she used what she called at the time reflex inhibiting patterns. And then she had the experience, and we all had that experience as well, that you sat the client back up and attempted to move, and all the inhibition that you thought you had gained disappeared. And you still had hypertonicity. You still had spasticity, because at that point, she used the words interchangeably, although they are not defined interchangeably anymore by the World Health Organization, okay? However, she realized that, and you know what she called those laying down and not moving things? They were not called afterwards reflex inhibiting pattern. She called it rest in peace. She said we should bury that. It was a mistake. And so it was a mistake, but somehow people continued for years and years and years to continue to teach inhibition separate from facilitation, instead of creating neutral, more normal alignments in weight bearing using the closed chain to get both inhibition and facilitation or activation of muscle at the same moment to allow movement, to controlled movement to occur. So when we started using the closed chain as a method of inhibition and facilitation, everything changed.
Yeah. It was I think the beginning of the force use, no? That concept of a closed kinetic chain. We will speak later about it.
Probably. I would say yes. I mean, Mrs. Bobath used the closed chain. As soon as she stopped laying people down and doing inhibition and realized that you could never get function unless the person was upright against gravity, she started therefore using the closed chain. The person was in the upright posture and high sitting and standing. So at that point, those two things were melded together. And she started making up what I would call now forced use paradigms, handling strategies that required the client to produce force against gravity in the involved body segments and disallowed overuse of the less involved body segments.
And also spasticity has always been the focus of therapy at Bobat, right? Spasticity was or is like hell, is it?
Well, in the beginning, at that same point that we're talking about, when spasticity was seen as the main problem, not a consequence of the lesion, then inhibition was preceded trying to move. Now, what we know now is, with the new definitions, makes it easier to understand that spasticity is a response to quick stretch caused by this response to quick stretch, which is evaluated in degrees of activity, how hyper it is, how great the response is to the quick stretch, is one thing. We can have normal movement, and still, if I give you a quick stretch after you've had a lesion, you will have spasticity. But you can also have normal movement. So the definition change would be that the way the person, when somebody reacts with increased tone when they move against gravity, is reactive and called hypertonicity. So when clients are moving, and let's say when they have instability at the hip, not enough strength to hold themselves up against gravity in a good alignment, and try to make a movement or step, and they can't maintain the alignment, and maybe their foot turns over and their toes crawl and all of that and the elbow flexes, we call that hypertonicity. It's a response. And as soon as the client would sit down and doesn't have to hold himself up or produce so much force against gravity, the response declines or goes away. So there's a difference between spasticity and hypertonicity. In the beginning, Mrs. Bobath used them interchangeably. In her writing, in one sentence, she would say hypertonicity, the next spasticity, because there was no definition. Now we've defined it, and we need to really look at that very seriously, because hypertonicity, because it is a response to a situation, it's reactive. Hypertonicity, it's reactive. We need to see what's causing this reaction, and that's what we are treating, the movement dysfunction. And a consequence of this problem is hypertonicity. But our treatment needs to be aimed at the cause of the hypertonicity. So, yeah.
You always speak of associated reactions as equilibrium or balance reactions to another problem, another basis problem, like the elbow flexion because of the general posture of the trunk.
Yeah. So it's very important that we recognize that if my hip falls back when I'm walking, I can't keep my weight over my foot, I will have a balance reaction. I will keep myself from falling down, and I'll reach out and try to stop myself from falling in whatever direction it is. Or I'll change where my feet are. I'll change where my mass is over my base. But I'm going to make an adjustment that we call a balance reaction. It's an equilibrium reaction. The client attempts to do that as well. His balance reaction or her balance reaction, the client's balance reaction may come together with abduction from the shoulder, abduction of the shoulder, like my arm does. But the strongest muscle in the arm, the biceps, then is also activated as part of it. And we see it, and Mrs. Bobath in the past, historically, saw that as hypertonicity or spasticity, rather than a balance reaction. We see it as a balance reaction. The person's losing their balance and is attempting to stop themselves from falling. The pattern just is different.
Now we know that there is some studies that show that a patient may have associated reactions, for example, during the gait or with the start of the gait, but this patient doesn't have passive stress reflex or spasticity. So maybe there is a confusion between the passive and the active condition, and probably Bobath finds it difficult to assimilate or to congregate to the therapy. What do you think?
I think that we're talking about something that's historical and in the past, and there's no answer to that question. We look at it differently now. We see it differently. We have more science that talks about what happens at that moment in time. So I can't relate it to Bobath anymore because there's no point in relating it to Bobath anymore. Historically, that was the case. We described it only one way, no matter what happened.
We can move from the evolution of Bobath, and I want to ask you, what do you think that the Bobath concept has evolved, for example, from the 70s to the 90s, or from the 90s to the new century? How do you see the evolution in global sense of the Bobath concept?
Well, you know that I became a Bobath instructor and taught Bobath courses. Over the years, I studied more, not just with Mrs. Bobath, and I started studying in the United States with Jan Utley and Isabel Bowman, both of whom were university professors, both of whom taught neuroscience in the university. And so over the years, we kept up with the changes in neuroscience, in the recognition of what plasticity was, in what conditions were required to influence that plasticity occurred. And we began in the guise of our Bobath courses. And because we believed exactly what Mrs. Bobath taught us very early on, early in the 70s, that the more science there is, the more you need to change your handling to observe those conditions that we know will cause the client to recover better. If we believe in recovery, and we believed in it in the 70s, we believed in it in the 60s, we still believe in it, so we have to change our handling to reflect what we now know about recovery or plasticity in the brain. So we changed our strategies. We increased the intensity of the strategy. So instead of, for example, instead of just working on sit to stand as a transitional movement pattern, we put the less involved foot up on a stool or a step of a ladder, so that when the client went to, and we put it in a not a good alignment, not the alignment you would usually use for using both legs equally during sit to stand, so that when the client stood up, the client was forced to activate the involved leg first and more. So it was exactly what Mrs. Bobath taught us to do, create a situation that activated the involved body segments. And we did it now with more intensity. So one thing we learned from Merznick, Jenkins, Paul Baccarita, Edelman, all of those people who studied recovery, especially Edelman, who really looked at dendritic growth, is that we needed more intensity to allow an extrinsic activity, what we did as therapists, therapeutic intervention, to cause changes, to stress the brain, to cause more areas to be activated that have the same potential, and cause dendritic growth or new synapses to be formed. So we increased our intensity in all of our activities. We also, over time, increased based on the information in different studies with Dr. Taub and Jenkins and Merznick. We also then chose to see the client not only in more intense situations, but for longer periods of time so that we could get more repetitions. This also came from the information on motor learning, which then also caused Jan Utley and myself to create strategies that would allow the client to learn to move again more easily. So repetition was one. And there were many other parts of motor learning that we incorporated, like progressively decreasing facilitation, not doing blocked learning, but having more than one activity at the same time so that the client didn't just perseverate or learn one movement pattern or strategy. We combined them into function, and all of that came from motor learning. So for us, the Bobath course changed dramatically starting in the 80s and 90s, where we included more intensity, longer, much more repetition, and motor learning principles so that the client could more easily learn new movement patterns. So we didn't belong. The IBITA, the Bobath Association in Europe, rejected what we had added into the course. And it became called American Bobath, which of course it wasn't. It was no different in Europe than it was in America. However, we were Americans, and therefore it was called American Bobath. So at some point, in the beginning of the year 2000, we decided we needed to retire from the Bobath organization and call what we did something else, which was the clinical application of force use, not forced use like in science, not forced use like in constraint.
There's a difference, yes.
The clinical application, we made up handling strategies that allowed plasticity or recovery to occur.
That's a good question, because in the literature we can see this concept of force use therapy. No, but it has not. It's not the same like the courses that you teach. It's a big difference. I get confused in the past.
It's been a problem because we use the words forced use in the title of our courses and what we're doing, because we were assuming that it was clear that we were organizing handling strategies that forced the client to use the involved body segments. It wasn't, and that's all it was supposed to mean, that the involved body segments were going to recover motor control. And for us, it was about clinical handling, management, the management that we would do as physical therapists and occupational therapists to influence plasticity or recovery of motor control.
In some studies that I have read, we can see that this force use concept is like the split belt, that they have two velocities, and this is forcing the more affected leg to move faster, or to put some weights on the leg to get resistance training, for example. And maybe it can be forced, but it's not the same as the exercises that you teach and you do with the bridging, the push-ups, the exercise with the ladder, and so much exercises.
Exactly. The thing about it is, we teach what we call in our courses the concept of organizing therapeutic intervention to force the client to make it possible for the client to activate and strengthen the involved extremities. We teach that, and at the same time to disallow overuse of the involved side, of the less involved side. So when the client doesn't overuse the less involved side, it means we've activated the involved side. Otherwise, the client is required to overuse his less involved body segments. Mm-hmm. So a force use paradigm is exactly that. It's an activity that involves all 5 body segments. It doesn't split the body in half and say, we're not going to use this half of the body. But what I would like to do is make sure that the involved body segments are activated, being strengthened, are accepting the role that they need to be in the activity, whether it's being part of the base of support as one potential role function or not, whatever it is. But in that case, we have both things happening at the same time. Mm-hmm. Less use or less overuse of the less involved side, and the involved side is being activated. Mm-hmm. So in that case, you're looking at something that is structured to disallow compensation.
Yeah. I am doing the basic course with Susan and Marta. We're still doing it. And what I can see is that the structure of the activities is very controlled. And that is a very impressive thing of the force use, that the patient cannot do anything more than what is planned with the activity, and we have to structure the activity in the way that we achieve that. So I think the difference between what is called force use in the literature and what they are teaching is quite different. You have mentioned a few minutes ago some of the difference of the European and American physiotherapy. And you have worked on both sides of the Atlantic. So did you find differences between American and European physiotherapy, if we can do this category of American or European?
Well, I've worked in Europe a long time now. And the reason that Jan Utley and myself moved from the United States in the mid-90s to Europe, to Switzerland, was the following. At that time, at that point, the insurance companies in America were paying for fewer and fewer hours, days, amount of time for each client. So that it came to the point that it was not, and the structure in the hospital also was that much therapy was being performed in groups.
Yeah.
So not specialized for each client. So fewer and fewer people started coming to our courses because they said, I'm not allowed to do and don't have time to do what you're teaching us to do. We believe what you're doing, but we, in our practices in the hospital, nowhere are we allowed to do it. The client has 2 weeks of rehabilitation. Half of that time we end up spending teaching the family to do a transfer, ordering equipment, and some of the time is used to treat the client. Mm-hmm. So Jan and I said, okay, I had lived and worked in Switzerland before and had gone back and forth numbers of times. And so I said, you know, in Europe, at least one thing is true. The client gets therapy. That if we do the right thing, we have the chance to help people. We have the chance to help these clients. And so if we give more courses there, we have the chance to be involved with many, many therapists who will then go out and really change what's happening and change the evolution of physical and occupational therapy. So we moved to Europe, and it was true. Many therapists came to our courses from everywhere because they wanted to learn how to handle.
Mhm.
They weren't so involved in what you're calling it, what name, what buzzword of the decade, you know, whether you're going to call it knowledge acquisition or you're going to call it forced use or you're going to call it whatever. They were much less interested in that. It was the beginning of the 90s, the middle of the 90s, and people were much more interested in being a good handler, trying to help their clients. There was much less social media and much less emphasis and communication through social media. And we had therapists from everywhere. In fact, our contact with the therapists from Holland, who had had a lot of training in orthopedics, helped us to start recognizing that our clients had orthopedic changes based on their inability to move, which meant that we would have to add mobilization for the neurological client into our courses. So coming to Europe, seeing clients longer and more, and therapists seeing clients longer and more, and that interaction helped us to continue our change from what we had experienced in America, which was fewer and fewer hours of therapeutic intervention and worse outcomes, as opposed to the outcomes that we were seeing and getting in Europe. And here in Spain, it's the same. People get much more therapy and many more hours, and their outcomes are better. More people go back to walking at least part-time. You know, Jan and I, when we measure our success with our therapeutic intervention in our practice, we measure it by how many clients go back to work.
Mhm.
Because the clients now are younger. They're not 70 and 80 years old like we saw in the beginning. They're younger and they have their whole lives ahead of them. And what we do, if it helps them to get back into the workforce and have their lives, then we consider it a success. And I still consider it a success that we have so many clients that go back to work. And that was always our goal.
It's interesting to know that situation that you have to treat more younger people than older people. So what is the difference between those type of patients? Have you noticed some difference? Obviously, yes, but what difference in the therapy, directly in the therapy?
Well, the first thing is the client's personal goal.
Yeah.
It's a lot different if you're 80 years old. Your personal goal may be to stay at home in your apartment. You may or may not care how much help you need or whether you walk or not. But you want to be able to have your private space and your things around you and your family. A client who is 24 years old and has a stroke has their whole life ahead of them and has seen a catastrophe happen in terms of what they had planned, like getting married, having children, going to university, those kinds of things. So the goal is not that we don't plan for somebody who's 80 to walk. It's not about that. But we recognize that each client may have their own goal. And we need to respect that goal. Not everybody has the same goal that I would like them to have or what I believe they could have. If I believe somebody can recover and I believe they should try to use their arm and I can set up activities so that they do it, but then they don't do it at home and tell me it's not important, what's important is, and then they know what's important to them. And I need to respect that. After I've shown them what is possible and they make the choice, I need to respect that.
Yeah, I agree with you. I also work with younger people, with older people, and I don't notice that difference because, or not much that difference because I have not lived in so long time ago. So, but I have experienced the change of mind, the mindset of the objective or goals establishment. Maybe at first the therapist. I don't know how to say. establish the goal for the patient, not the patient himself. And that's a change that is very important to do. Maybe we have the idea that we are the professional, we are the authority in this kind of knowledge, and we have to say to the patient, oh, you have to work, you have to return to work, you have to walk 5 kilometers per day, but maybe the patient has not the motivation. So how do you manage this discordance, these different opinions with the patient and therapist?
Well, there are a couple of things I think about that, and probably it's easier for me to think of them now because I'm older, but I was very rigid in this goal setting thing. I felt like I believed that if I showed the client what was possible, then the client would choose the same goal that I thought he could reach. Okay. So if I showed him he could stand, and I showed him he could walk, and I showed him that I believed in it desperately and that I would help him achieve it, I believed that the client was going to choose that. And that now, as I got older, I recognized that was much more about me and trying to be a miracle worker or trying to be the best handler possible, which I still would like to be the best handler. But it doesn't mean that the goal is my goal. The goal needs to be the client's goal. Now, I don't think you shouldn't show them what is possible. I think that the client can't make up the mind or his or her mind unless they know what's possible. And in the beginning, they're in such a desperate situation, catastrophe has happened in their lives, that being able to show them what would be possible helps them to make better choices. And I think that's important, but I don't think that it's supposed to be about me. I think it's supposed to be about the client and the client's family. However, there is research, a lot of research about different cultural differences and age differences in how we help clients change, make goals. And it's culturally, it's very significant. Age-wise, apparently, it's very significant. You know, we grew up believing, my generation, that if you put all the people with strokes together, like you put all the people with spinal cord together, they would make a competition and they would help each other reach their goals and all of that. And what the research shows is that when you get to be somewhere like over 25 and 26 and have started your life and you have maybe a partner or a girlfriend or children, what the person in the next bed is doing is not interesting. Your family and your life is interesting. And so that actually doesn't particularly work in terms of helping people make better or different choices about goals. We also know that there are different cultures that don't believe that after you're a certain age, you should even try to get better. The family will take care of you. So choosing goals is really very, very difficult. And it really needs to be something that happens between you and the person after you have a relationship. It's not about you standing over somebody in their wheelchair or their bed and saying, I'm going to teach you to walk so you can go back to work. I'm glad the person knows that I believe that, but it doesn't mean he has to choose or she has to choose that. It's a problem, I know.
But if we have a thing to completely say that is we have to show that what the patient is capable of. That is a great revolution in therapy, and that it's not a therapy, it's not a technique, it's a philosophy, I think.
I think it is too. I think until the client actually believes that he could get out of this situation and you've shown what would be possible, it's really hard to make a considered or an intellectual choice. And the client should be allowed to change his choice. Some people actually go home in a wheelchair and recognize what that means and then say, uh-oh, I really need therapy. I really would like to do this and the other. And then they work like crazy to get to their goals after that. So it's different in all cases. And that happens a lot in America where the amount of rehabilitation time is so limited the person ends up going home, and they're lucky if they get one good therapist. It doesn't have to be a physio. It can be an occupational therapist. It could be a good speech therapist. Whatever, one good therapist helps them to see what they could do and that it doesn't have to stay like this. And then we work to get them back in therapy. And then the therapy means something to them. So there's a lot of different choices that have to be taken into consideration.
Mm-hmm. Yeah.
And you've seen that in spinal cord injury. There are many people that end up going home who then come back and work like crazy to overcome many of the problems they have with their disability.
Mm-hmm. Yes. I would like to finish with the BOBAT topic that we were talking about earlier. We move around the tree with different topics, but we have to return with the BOBAT and finish it. You have talked about the evolution of BOBAT, but there are some Delphi studies, some consensus studies where there seems to be not consensus on what the fundamental characteristic of BOBAT are. The only thing that seems essential is the concept of facilitation. Intensity seems to be taken for granted, but when you see BOBAT treatments, at least in Spain, what you see is a lot of facilitation, a lot of passive techniques, a lot of consciousness about the spasticity of the muscle tone, but not a lot of intensity, like the cardiovascular intensity, repetitions, or intrinsic intensity, like the force use paradigm. So perhaps there are differences between what I have seen in Spain or in other European countries, but this concept of intensity linked to BOBAT, I don't see it here in Spain, at least.
I don't know what to say to you because, in fact, we left the BOBAT Association because it wasn't changing with the continued research in recovery of motor control, with the continued research in what are the characteristics that allow plasticity to occur in the brain. Nothing changed. The only thing that I saw change in Europe in terms of BOBAT was more hours.
More hours.
Okay. But I didn't see anything change in relation to handling strategies. As you said, it was there was a lot more passive activity. Then there was facilitation. And there are many people that even believe that you shouldn't get up and attempt to walk if, when you're walking, you have a increased muscle activity, hypertonicity in the arm. If that happens, you should sit in a wheelchair and wait for it to go away. I've seen that in Norway. I don't know if it's still happening in Norway, but I know BOBAT instructors that taught that in Norway and in Sweden. So I'm not the authority on what BOBAT is doing. I left the association with Jan Utley and started our own association in 2001, I think, which was called IFUSA, International Forced Use Association, okay? Mm-hmm. And we didn't call ourselves BOBAT because we continued to change the handling strategies to reflect the new neuroscience, the information in neuroscience. Now, the real truth is, I believe that Mrs. BOBAT would be jumping up and down and happy with what we're doing because she believed we should keep changing. She believed the clients could recover. And if anything we had to do to make allow or influence that the clients recovered better and more fully, she wanted to do it. And that's why she changed herself and her handling strategies over the years so she could get more complete recovery. And so I think she would be upset and angry if she saw people doing what she did in 1975 or 73 today in 2021.
I wanted to get to that point, Susan, because I've heard you in some occasions that you comment that if the Bobats came back to life, they would be surprised at what some Bobat therapists and tutors have done to their concept. Why do you say that?
Because not changing, keeping the client more passive, not understanding the difference between hypertonicity as a consequence of lack of stability, all of those things would make her crazy, because now we know why we need to do it. We know what causes that. We need to develop handling strategies. As I said, I think I had a girlfriend, a friend who works in Germany, who had the same discussion with a Bobath instructor who had given a course, and she felt that the client was worse after the treatment than before, based on the handling. And the instructor asked her what she thought about it. And she said to him, if Mrs. Bobath woke up today, Mrs. Bobath would die again if she saw what you just did. And that's how I feel about it. I think Mrs. Bobath would die again if she saw that nothing had changed since 1970 or 1975. I just find it reprehensible. So people don't like that we call our course forced use. It doesn't matter to me. It's just words. What we're trying to do is help the person recover motor control by using certain handling strategies that have been, and the characteristics of which have been found to be helpful in terms of causing plasticity in the brain. Mm-hmm. And that's what we're trying to do, recover motor control.
So do you think that there has been a problem with this expression that say, keep it pure, no? Or don't kill the father? With an idea or a philosophy or a concept, and maybe the therapists that are doing Bobat don't know how Bobat was or what philosophy he developed. So we have to speak with persons like you that can say that change is well, and we can change, and we can. Evolution. And I think when I speak about forced use to other colleagues, that I think the forced use is like it takes care about the facilitation. Obviously, it's a very skilled handling, but it has the intensity inside. So this is an evolution of the handling strategies of the past.
It really is. And the thing about it is, I come from a generation where social media wasn't in charge of my life, okay? So if I looked at what we're doing, we could call it HIIT, high intensity training, which is a fitness direction, which I do myself when I train for myself. What we're doing with the clients is not different than that. It's high intensity training aimed at acquisition of motor control. And what we know about it is that it produces changes in the brain that lead to plasticity, dendritic growth, new synapsing, activating neurons that have higher level thresholds for firing. All of those things happen under these conditions. We call it forced use. It doesn't matter actually what we call it. Mm-hmm. And for me, I just was looking at something in the media, and it was a really good course, and I'm thinking of taking it myself. And they call it knowledge acquisition. And I thought, my God, all learning is knowledge acquisition. That's just as vague as HIIT, high intensity training, or forced use. It's just verbiage. They're just words. You need to see what's behind the words until you can understand what's good or bad and make your own choice.
I agree with you. So we can move to another topic that is very interesting, I think. When I speak with therapists have some experience, let's say more than 10 years, they often comment that they have gone through various stages or key points in their professional life. Points where they have considered changing their way of working and exploring the other options. In your case, how many of these paradigm shifts have you experienced, and why did they occur?
Okay, so in my life as a physical therapist, the biggest paradigm shift was the paradigm shift I described to you when I found out that I was allowed to make up the handling strategies and the reference point was normal. That was my first paradigm shift. And probably it was the shift that has directed my entire life. However, the goal of better and more complete recovery has allowed me then, or was caused, my belief in more complete recovery caused me then to look for other people who were also looking at the science and the research and trying to create new handling strategies that were more effective. And that was Jan Utley at that point and Isabel Bowman in what it was the American version of IBITA, which is the NDTA, Neurodevelopment Treatment Association. It was exactly the same. It was the Bobath Association. It was the name Mrs. Bobath gave to us to use in North America. And having met those two women, I learned to use the research more to make up handling strategies. And with Jan Utley together, from about 1990 until now, at this point where we're getting ready to retire, we continued to create more handling strategies, new handling strategies, change our handling strategies based on the science. And that was the paradigm shift of my life.
Okay. And there is something in recent years that has made you change something in your clinical practice, because we have this fashion of technology, for example. You know that here in Zen, we apply a lot of technology and it can be part of a new paradigm, for example. What do you think about these recent years of explosion of technology, and it has been an impact for you in your paradigm, your philosophy of treatment?
Okay, so there's two or three things I want to say about that. In my practice, I have no machines, but I do go to the gym with the client and use machines and create with those basic fitness club machines for strengthening force use paradigms. And it's been incredibly helpful, number one, in getting the client into a social situation with lots of different kinds of people and allowing us to achieve strengthening more quickly. And so using the gym and the equipment in the gym has been a big shift for me and something that I absolutely believe can be totally helpful in recovery of motor control, and definitely in terms of strengthening and the coordination of all 5 body segments. Now, the other machines, as you know, I don't have a lot of experience with the other machines. I've been looking at them at Zen while people use them, and I think, for example, each one of them that I've seen, like the C-Mill, the treadmill, and the Lokomat and the Ryzen have their place with different kinds of clients. I would not use them with every client. I would not use them all the time. That means at a certain point, the client may not need a certain machine anymore, or to use a certain, I would call it assistive device. Okay.
Yeah.
However, I can see that the client can achieve certain functional goals more quickly. For example, one of them being better cardiovascular a better cardiovascular situation. For example, on a machine like the Lokomat, the client has, number one, mobility. That means that you help to diminish the effects of immobility in joints and lengthening and shortening of muscles and capsules. there's weight bearing, and there's a cardiovascular effect. I think this is a really good machine for those kinds of things, especially when the person is more sedentary and
non-ambulatory patient.
Non-ambulatory for more than 10 minutes or a half an hour in a day. Yeah, I think it's a great machine. What I would change about that machine is what you all are exploring now, getting more and more weight on the feet so that
the hip extension.
Is more active. Yeah, exactly. Going the next step. You've done this, and now we have to get to this. It has to have more weight. And all of those, and all of the activities, I also think something like the Ryzen, where you can make the person safer, they won't fall down. It requires fewer people to handle the client, but there's always the possibility with every machine that it can be abused. You put that on the client and they walk in any way, and then they practice any pattern. Or you can facilitate the client and get more normal movement patterns, and they're moving and walking more, and they're safer while they're doing it. And therefore they try harder because they know nothing bad can happen to them. There's good things and bad things, like always. But that's the same in any kind of situation. I think that we have to be very careful, however, in not overusing the machines. When the client is walking on his or her own, we need to really make sure we know what the goal of the machine is. That the machine isn't just there to be used and to make money. It's about reaching a goal more quickly and more completely. And I think with the machines that I've seen at SAM, that's possible. That you can really enhance the treatment and getting to the goal faster.
I have some experience with the concept of machines, because when I started to work in a center like Zen, but more lesser machines. But we have a robot that is called GeoSystem. It's an N-Effector robot, and it was so great. And we have to get publicity of this device. And I have used the GeoSystem robot for 2 years when the patient did not need it. And there was the dusty treadmill right there. No? So I recommend to newly therapists to start working with no machines, to establish a good handling skills, and then comes the technology with the clinical reasoning. So I think Susan is right, because we have to reason, to think about the technology and what are the active ingredients of the technology, and not used by I don't know, by normal bad economy or by normal treatment. We have to be intelligent with that.
Oh, I'm glad to hear that. You know, there's so many things that have changed when you think back over the years. When I finished the university the first time, and I got my Bachelor of Science, you weren't allowed, for example, to go on and get a master's. You needed to have 5 years of clinical experience to go back and do a master's and then do research. Of course, that's disappeared now. You can go all the way through and get your DPT, Doctor of Physical Therapy, without ever 1 day of clinical experience. That's a problem for me, because the kind of research we get then is not applicable and doesn't have a deep seed basis in clinical experience and clinical problem solving. And I think, I think it's something to think about in this machine. The idea that you have that you should work in a place without machines first and learn how to handle absolutely speaks to me in that way, because then I know what my clinical problems are, and I then can find out what machine could help me achieve that, the solution to that problem more completely.
Yeah, it's true. You talked lightly about Edward Taub before, and everyone knows CI therapy, I think. But I thought that the experience with Edward Taub was part of the paradigm shift. But you didn't mention. But what did you learn from him, from Edward Taub, the CA therapy, that revolutionary concept?
Yeah, I mean, for me, when I look at CIMT, when I look at constraint, I look at somebody who recognizes you have to set up a condition of practice in which the client is, to be successful, is required to use the involved body segments. And in this case, it was the arm. And I had a client who went and was in one of the first Excite studies. She was the practice client and came back this was very interesting. We had worked with her for a very long time. She had a stroke. The first time we saw her arm looked like it would fall off of her body if she didn't have skin. That's how hypotonic and disused or not it was. Anyway, she came to a course, Advanced Gait, and we did some what we call our bridging. We hadn't developed push-ups at that time. And it was in, I guess, the late 90s. I think 98, 99, something like that. And after that, she started being able to move her arm, and she made this joke. I had to come to a gait course to learn I could find out I could use my arm again. And then she became very interested and followed us to Chicago. And she became our first client with forced use. And we actually used constraint with her as well as our handling strategies. And she got a lot better and still didn't have a lot of control of her hand and fingers. And we showed her video to Carolee Winstein, who was one of the professors who were part of the Excite project from the University of Southern California. And she had taken our Bobath course years ago in Sacramento. So we knew her pretty well. And so we sent the video. She looked at the video of this woman and said, oh, she could be the practice client. So she went off to California. What happened there was she came back to us having done almost all of the activities for the arm in sitting. She came back weaker, walking worse, and her shoulder was killing her. But she could move her hand and she could write and she could pick up raisins. And so that was sort of a very interesting piece of the justification that we're continuing to build, that it wasn't just about constraint and just using one piece. It was the synergistic organization and the coordination between all the body segments that was important. And so every activity that we devised always has all 5 body segments. So in order to get motor control, we have agonist and antagonist interplay. Using the closed chain, we have antagonist and agonist activation at the same time to get more graded movement. So we learned a lot from Dr. Taub about how to do it and how much we had to force and how extreme we had to be to force the involved body segments to become active. But we also learned that we had to continue to involve all 5 body segments for coordination and regaining the access to motor control. So that was one thing. In 2002, we got funding to do a research project in LA. We were funded by the person who owns a television channel there, whose daughter had had a head injury. And what we wanted to do was test our handling strategies, our forced use paradigms, like some of which you have learned in the course, okay? As well as test the effect of mass practice and what order to do things in one sequence. So that was part of it. And we spent 10 weeks doing our research with two groups, one group that could not move their arm or move their hand without therapeutic intervention. And the other group could already move their arm. We used the same criteria as in the Excite project and couldn't use their hand at all. They could open it themselves and put it on an object. And we had to change the testing, the scoring of all the tests that Dr. Taub used, the Wolf Motor Function Test, because all of our clients at the end of all of this, the clients could all reach, they could all get their hand open, and but they had to put it on objects, and then they could use the object like to drink or to reach or to carry things. But with the scoring that the constraint of the Dr. Taub used for constraint, all of our clients still got 0. Yeah. Even though they had achieved a functional level that allowed them to use their arm at home. And that was very interesting to us. We had to change the scoring. There was using the scoring that was already present and that was accepted in the scientific community. Our research was a bust. It was 0. Everyone got 0. However, everyone could functionally use their arm afterwards. Everyone could functionally be out on the street. Everyone could ride a bike. We all went bowling. We could do things, wash the car. However, everyone still got 0 with the testing procedures. It was very interesting, and it was part of a paradigm shift that we had to then think of how we could show that the handling strategies we were doing actually made a functional difference in the client's life, and that we were getting recovery. That was very interesting. That happened in 2002, and right after that, we retired from Bobath and started the Forced Use Association.
Mm-hmm. That remember the conception that the upper limb is only useful if fine manipulation is possible. This conception leaves patients without treating the upper limb, the negligible treatment. No, the upper limb is always forgotten.
Exactly, because for us, the being able to manipulate with your hand is not important. Being able to hold something, grasp something, have something in your hand, to stabilize a bottle while you open it with the other hand, to hold the glass while you pour with the other hand, and then to be able to drink, doesn't require manipulation. It requires gross grasp. For us, the holy grail of arm function is reaching and being able to move something around with something in your hand. Mm-hmm. It's a different viewpoint on what arm function is.
Mm-hmm. Speaking about the CI therapy, Edward Taub, did you hear Edward Taub recently at the same course? What feelings did you have? Could you listen to him in the course?
Yes, I did. I have to tell you, I think he's a brilliant man. And I hope that I'm as active when I'm his age. I'm already getting towards his age, as active at his age with my mind as he continues to be. He did something very brilliant. He really helped us with the paradigm shift in terms of therapeutic intervention. And whether I use constraint in conjunction with what we're doing or I don't use it with everybody makes no difference. I think the idea that we know how we can activate the upper extremity, how we can influence plasticity and recovery, and that recovery is possible, much of that is due to his research. Mm-hmm. And that was a big step, and he went through a lot. You know his history. He went through a lot in his history in order to get to this place and help us get to this place.
Edward Taub has 90 years old, right?
Mm-hmm. So he's a little older than me, but not that much.
I don't know if I can interview him. Maybe. Bueno, we have this this conversation, this course that we can revisit. I have access to that moment, so it's so so emotional, I think. CI therapy treatment.
When I thought of something I wanted to say. I said there's something else that I think is really important that has been part of a paradigm shift in my mind and needs to be a bigger paradigm shift in everyday treatment of clients, and that is motor learning and the principles of motor learning, how you structure the therapy so that the client can learn more quickly and more completely. So they're not just copying and then they have no access to it the next day, so that there's real learning occurs. I think that needs to be part of the paradigm shift that we have in all of our treatments, whether we're using machines or we're doing manual handling or we're doing forced use paradigms. How the repetition is set up, how the activity is set up is very important in terms of repetition and integration of patterns.
I want to ask you more about the CI therapy, because force use uses a lot the closed kinetic chain, but CI therapy is the fundamental open kinetic chain technique, is the open kinetic chain technique for excellence. So how do you manage these two concepts of open and closed kinetic? Maybe I understand the CI therapy like massive practice. After the preparatory activities, the force activities, the activation, we can involve the upper limb with open kinetic chain activities.
Okay. So when Dr. Taub began, he didn't do this, but it developed into this. It developed into an open chain thing because they used people who had learned non-use. All of the subjects in the research had learned non-use. That means they were already moving their arm. Okay? And if you look at the videos, which I took David Morris's pretty much his first course in the late 90s in SIMT, okay, in San Francisco. And every time I looked at those videos and when I was watching them and taking the course again recently, what I look at is, sure, he has learned non-use, he's already moving, but the patterns of his movement are not getting better or more graded. And so he practices like babies practice. And after thousands of repetitions, the movement pattern becomes maybe more optimal. Okay. Then the question for me is, if recovery can occur for these people, why can't it recur for everybody? Recovery is recovery. Plasticity is plasticity. The definition is the definition. So taking people who don't have learned non-use, not moving, setting up conditions to activate skeletal muscle required activation of agonist and antagonist in the closed chain. That was our mode of activating skeletal muscle through skin receptors, processed at a spinal cord level, requiring about 45 milliseconds, and therefore initiating muscle activity. And it was phasic. But if I was in the closed chain and kept moving over the distal component, whether it's the hand or the foot, I keep initiating muscle activity. At the same time, the person is moving, so he has movement receptors in joints, approximation in joints, change in length in muscle. So processing at higher levels occurs. So we get brainstem and cerebellar and finally cerebral activation by using the closed chain. And that's what why we're doing it, because to have controlled muscle activity or controlled movement patterns, I need agonist and antagonist interplay. The old style of facilitation, if we can get back to that, because this comes as part of it, we had the choice. Dr. Taub, they didn't handle and the person moved themselves, or we could activate, like in the old way, one muscle at a time, phasic. Even Mrs. Bobath figured that out. The minute she stopped facilitating, there was no muscle activity. In the closed chain, we have a continuation of muscle activity. Yeah. So that the client can begin to use the muscle activity in full patterns, not one muscle. And therefore, we use the closed chain. We use what the body has given to us.
Mm-hmm. I noticed that the closed kinetic change is very useful for very severe or affected patients. We think that we can do anything, mere compensation with the other upper limbs. So I think these exercises can be very useful in a first stage of rehabilitation, and also for very difficult exercises, very demanding exercises like bridging, like push-ups, that can work on that and agonist and antagonist interplay that maybe is the essence of the tone modulation, would influence the voluntary activation of the muscles. So I think it's clear that these exercises are very good at the initial treatment.
I think absolutely. You can treat the earliest client, the client who hasn't demonstrated any muscle activity, the one that in English we would call flaccid. The therapist and the doctor and nobody feels any muscle activity. You can cause muscle activity. This is way below I used to say 100 American miles away from the level of the lesion. You're not using any of that part. You're using a system that's intact to activate skeletal muscle. Mm-hmm. The client also gets sensory feedback, just like a baby when they start moving doesn't have full myelinization and doesn't have graded motor control, but they're moving. And as they start moving and weight bearing and moving themselves around, they not only start grading the movement because they have interplay between agonists and antagonists that they don't have when the arms are not in weight bearing, but you also get sensory feedback. You know if you're doing the right thing and you're successful, you feel safe or stable. You have all of that kind of sensory feedback that's built into that situation.
Mm-hmm. What we are talking about reminds me of an idea that always is in the courses or in the rehabilitation paradigms, that is that phrase of you can only move what you feel or what you sense. What do you think about this phrase?
That's a lie. That's a misnomer. Something that we didn't understand, but we do now. We know even with babies, there's not full myelinization at birth. And the babies move around. They can move. And then they start weight bearing. And they have slowly continue with myelinization. They don't have and build sensory feedback through movement. People who don't feel their leg can walk. They can't grade the movement. Grading the movement requires more sensory feedback. Fine motor control requires more sensory feedback, not less. Mm-hmm. So actually, Dr. Taub, in his early research with monkeys when he was still at Columbia and a graduate student, and he was working with Sherrington, did some studies that showed if they cut sensory bonds, sensory tracts, that the monkeys could still use their hand.
The dorsal root of the dorsal root, yes. No?
Yeah. So that's a misnomer. It's a mistake. And even in my day, in the early 70s and in 60s, when I was in the university in the 60s, we believed that, and we were taught to test practically every millimeter of the person's body for their ability to feel, cold, hot, sharp, dull. We picked, everybody did it, from their face to their arm, over their whole body. And every day we perseverated on our experience and whether they could feel. And we made very bad and enormous choices for the client, which one would go to rehabilitation and which one would go to a nursing home based on that.
Mm-hmm.
He can't feel, we send him to a nursing home. He has no chance of ever moving correctly. It was very, I have strong feelings about this.
So Susan, hours and hours of sensory stimulation, and it was like a leap of faith that the movement will appear.
Yep. Yep. My grandmother from Russia used to say, "What you know and heard in the course, nothing comes from nothing." You can stimulate a sensation, but it doesn't mean movement will happen. It may or may not. But movement will, the reverse is true. Movement will cause you to have a sensory experience.
Yeah, that leap of faith is is also seen in Bobat concept when you do some analytic exercises. The tone is so good, so modulated that, but the patient leaves the clinic and associate reactions and all goes out. So is that
it's like the therapy fell off or stayed in the clinic.
Don't want to see the patient outside the clinic.
Yeah.
Okay, so Susan, I think we can finish with the first part of the interview. In the second part, we can talk specifically about Forced Use and also some other experiences with therapy. Would you like to say something more about everything we have said by way of summary or something like that?
Not really. What you know from what I've said is that I believe in recovery of motor control, but I also believe what I just said, nothing comes from nothing. We have to set up the experience of the client. We have to control the therapeutic intervention to cause plasticity. We are doing something extrinsic that causes a change in the brain that requires consideration. That means every activity that I do, I consider the client's problems and the consequences of his problems when I set up an activity. It's not a cookbook. Every single time it looks different, and it needs to be a consideration about how the problem expresses itself in each individual client. Okay.
Thank you very much, Susan, and to the audience. See you in the second part, where we will talk about Forced Use. And thank you very much for watching, for listening, and bye-bye.
Bye.